what is the result of a failed abortion? It's a living baby. Isn't that true?
Exactly. Yes, exactly, which tells you all you need to know about what the intent of an abortion is. It's important to understand what an induced abortion is and what its intent is. Its sole intent is to produce a dead baby. A procedure that is intended to produce the death of my preborn patient has no place in the practice of medicine. It is not healthcare, it's not needed, and it's not practiced by the vast majority of OB-GYNs.
When it comes to women's health, few conversations are as clouded with confusion and misinformation as the issue of abortion. What does real life-affirming medicine look like? How do physicians navigate those heartbreaking cases where both mother and child face medical risk? And why is the Hippocratic Oath, once the foundation of all medical ethics, being pushed aside in modern medicine? Today, we sit down with Dr. Christina Francis, a board-certified OB-GYN, a missionary doctor, and now the CEO of American Association of Pro-Life Obstetricians and Gynecologists. From her work on the front lines of maternal care in Indiana to shaping the national guidelines for doctors across the country, Dr. Francis is leading the charge to restore integrity and truth to women's healthcare. This is Living Pro-Life. Well, welcome, Dr. Francis. Appreciate you being on the program.
Thanks so much for having me. It's great to be with you.
Well, there's a lot going on in the pro-life movement. Even in a post-Dobbs America, there are many different things we should be talking about. But there at AAPLOG, you guys are doing a lot of things, not just specifically related to abortion, but across the spectrum. And I know AAPLOG does a lot with regards to creating guidelines. And I know you guys recently just put out some important guidelines. Could you touch on that just a little bit?
Yeah, absolutely. Well, just a tiny little bit of background, I know we might get into this more later, but AAPLOG, the American Association of Pro-Life OB-GYNs, is a professional medical organization, the largest actually in the world, that represents life-affirming medical professionals. So not just OB-GYNs, but physicians of many specialties. We have midwives, nurses, mental health professionals. So really anyone who's providing healthcare to women who desires to practice life-affirming medicine has a place at AAPLOG. We've got about 8,000 members across the country now. And one of the most important things that we do for our members is we compile the medical literature, sort of boil it down to what is practical for them in their clinical practice. With regards to the life issue, specifically at the beginning of life. And so certainly, as I know you're aware, and I'm sure your listeners and your viewers are aware, since the Dobbs decision, we have seen medical misinformation surrounding abortion just run rampant. People calling things like miscarriage care or ectopic pregnancy treatment an abortion, which of course we know that's not the case. And so it's really important that physicians and other clinicians in practice have good guidance as to what can they do legally in their state if they live in a pro-life state, but also just critically looking at what is an abortion and what is not an abortion. And this is something that I think many people sort of inherently understood before the Dobbs decision. But since Dobbs, as I said, there's been a lot of misinformation. And so there's just been a lot of confusion over that. And so this newest document that we put out is looking at those thankfully rare, but times during pregnancy where mom is facing a life-threatening pregnancy complication. What does that look like for those of us who are life-affirming pro-life medical professionals? How do we determine, is this intervention that we're thinking about ethical or not? Is it moral? Is it respecting the dignity of both of our patients, both mom and baby? Of course, if this happens after the point where baby can survive outside of mom, there's no question. You just get mom delivered and you take care of mom and you take care of baby. But unfortunately, sometimes these circumstances happen prior to that point. So at a point in pregnancy where we know that baby is not going to be able to survive outside of mom. These are very, very difficult circumstances. Oftentimes these are very wanted pregnancies. Of course, we know that baby is valuable regardless of if he or she is wanted. But, these often are circumstances where we're sitting down at the bedside of our patient, making this heart-wrenching decision with them of, we're at a point now where we don't have a choice. We have to separate you and your baby because otherwise we're going to lose you both. And so, those are very difficult circumstances to think through. And we have a lot of physicians that come to us and have asked, can you help us think through these situations? How do I decide what would be an ethical intervention and what would not be? And so that's what this latest document goes over.
There's a lot over in the abortion industry or Planned Parenthood who say, well, one, that any abortion is just fine, but they talk about this like, at the bedside or these kind of things. So a woman who is, let's say, 20 weeks along, had an ultrasound that didn't go her way, didn't look good, and she is, she's not in pain, she's not in the bedside, she's not in the hospital setting, but just driving into a Planned Parenthood casually to get an abortion. Tell me about those circumstances, because they're being told by some physicians that, oh, you have to do this to save your life, but it doesn't seem like her life is in danger if she's driving into an abortion facility.
Yeah, absolutely. Well, life-saving interventions that are done to prevent the death or permanent physical impairment of a woman, those are not being done at Planned Parenthoods and abortion facilities, as you just referenced. Those are being done in hospital scenarios where I work. I work as an OB hospitalist, so I only work in the hospital setting now. That's when we're doing these interventions to prevent mom's death. Even if mom isn't actively dying, there are still circumstances where you can foresee there's a high risk of that happening, and so you might need to intervene. And as you said, if it's I don't want to minimize the pain that women and families go through when they have an ultrasound that maybe shows something is wrong with their baby. Maybe they think their baby has a genetic abnormality or some other kind of birth defect. Obviously, that's a very difficult situation for the entire family to sort of come to grips with the fact that this baby isn't going to have the health that maybe we thought he or she was going to have. But you're right in that that's not a life-threatening situation for mom. It may be a life-threatening situation for baby, depending on what's going on. But that's not a situation where we need to intervene to separate mom and baby. In that situation, if a woman is having an abortion, that really is completely an elective abortion. There's no medical indication for ending that woman's pregnancy. And I think it's good to point out another point that sort of goes along with this, in that it's important to understand what an induced abortion is and what its intent is. Its sole intent is to produce a dead baby. And in fact, the CDC's definition is consistent with that. AAPLOG, the American College of OB-GYNs, who is unfortunately a very pro-abortion advocacy organization now, not really a professional medical organization when it comes to the issue of abortion anymore. But their definition agrees as well that that's the intent of an induced abortion, is to produce a dead baby. That's not our intent when we intervene to save the life of a woman if she's maybe 18 or 20 weeks and facing a life-threatening pregnancy complication. As you said, she's not going to a Planned Parenthood or another abortion facility. She's going to a hospital under the care of her physician who has a relationship with her, which is also very different from the abortion scenario. And we don't walk into that patient's room and say, we need to do an abortion, because we recognize that it's not. Oftentimes we can do a delivery where we respect the dignity of that preborn child, give that family an intact child that they can hold and grieve. If that baby is too early, that we're not able to do anything, unfortunately, to save his or her life.
Well, I mean, you heard about these failed abortions. Well, what is the result of a failed abortion? It's a living baby. Isn't that true?
Exactly. Yes, exactly. Which tells you all you need to know about what the intent of an abortion is. That, in fact, it was in a national paper, I think back in the 80s, where the headline was the dreaded abortion complication. And it was a live birth, actually, a baby born alive after an attempted abortion. So that's the intent of induced abortion. That, a procedure that is intended to produce the death of my preborn patient has no place in the practice of medicine. It is not healthcare. It's not needed. And it's not practiced by the vast majority of OB-GYNs.
Well, you just called them preborn patients. I think a lot of those in the abortion industry wouldn't even consider them human beings, if not, certainly not persons, and absolutely not their patients. So tell us a little bit about that nuance.
Yeah, absolutely. Well, to me, that is one of the greatest joys and challenges actually of being an OB-GYN or any specialty that cares for pregnant women during their pregnancy is that we are taking care of two patients at once. In fact, that's one of our mantras here at AAPLOG is that we have two patients that we're caring for, both mom and our preborn patient. And our job is to take excellent care of both of them. And thankfully, normally, we're able to get good, healthy outcomes for both of our patients. There's a lot of things that we do in obstetric care that might, be seen by some, I suppose, as like a burden on mom or asking mom to take on something that she otherwise wouldn't have for the benefit of her baby, our other patient. We might put mom in the hospital for weeks on end sometimes, not because it's benefiting her, but because it's benefiting her baby, our other patient. And so it really is such a joy to be able, and a challenge as well. I mean, sometimes that is very challenging thinking of how am I taking care of both of these at once? But it also is very evident. It's interesting to me. I've often joked that when a pregnant woman gets hospitalized for anything, even if it's something that is completely unrelated to her pregnancy, the other specialists are almost never the ones who will admit that patient. If she's pregnant, they want OB-GYN to admit her, and then they will consult on her for whatever issue it is that she's having. And why is it? Is it because they don't know how to treat her? Let's say she's being treated for an ulcer or something like that. Is it because they don't know how to treat her ulcer? No, absolutely not. It's because they recognize there's another human being at play here, and they don't want to be responsible for
Right.
taking care of one other human being. So, so every doctor out there, even if they are pro-life, they recognize that that's another human being, and they don't want the liability of trying to take care of both of them, without having an OB-GYN on board. So it is widely recognized within medicine that that is another patient, even if people aren't actually articulating that.
Well, we again are speaking with Dr. Christina Francis, the CEO of AAPLOG. Let's switch gears and let's talk a little bit about you. And you're now the CEO of this incredible organization that's was founded, I believe, in 1973. You can correct it if I'm wrong there. But how did you get to this point where you decided to get into medicine and eventually be the CEO of this incredible organization?
Yeah, well, for those of you who are believers out there, this will resonate with you, but I think God does laugh at our plans sometimes when we say that we know exactly what we're going to do with our lives. But I went to medical school intending to go on the mission field to do medical missions full time. And so as I was thinking through what specialty I was going to go into, I really was thinking through things that are very sort of broad, general practice, family medicine, pediatrics, something like that. And it was during my second year of medical school. So before I'd done my clinical rotations, I was shadowing a family medicine physician. And he got a call from the hospital that one of his patients was close to delivery. And so he said, let's go over to the hospital. So I went with him and stood sort of in the back of the delivery room, just observing. And when the baby was born to a woman who I'd never met before, I started crying because I thought it was the most beautiful, miraculous thing that I had ever seen. And there was this older, sort of seasoned labor and delivery nurse who was waiting by the baby warmer to take the baby after the baby was born. And she saw me crying and she leaned over and she whispered in my ear and she said, "Oh, honey, if this makes you cry, you need to do this for a living." And I have thought so many times that I wish that I could go back and find her now to tell her how much she changed the course of my life, really, because I had not considered OB-GYN before that. And so that was my profession actually chose me. My specialty chose me. I didn't choose it. That was the moment that I knew that that's what I had to do. And then, of course, realized that OB-GYN was actually wonderful training for the mission field. Oftentimes, in the developing world, especially women and children are those that are suffering the most from lack of access to good health care. And you get surgical training, which is also great for the mission field. So I completed my training, completed my residency training, and then went to Kenya to serve at a mission hospital there and absolutely loved it and really thought that's where I was going to be for the rest of my life. It still has a very special place in my heart, always will. I spent a total of about 3 years there, but in the midst of that was back in the States for a while. And my best friend called me one day, and I have often said since then that everybody needs somebody like this in their life, somebody who's going to just sort of say it like it is. And she called me because she had been participating in a 40 Days for Life event at her church. And her pastor, I think this was such a wonderful exhortation to the congregation. I would encourage anyone listening who maybe isn't super involved on the abortion issue to take this and do it. But he challenged them every day for that 40 days to either read or watch something about abortion, even if it only took them 5 minutes that day. Just every single day, just read or watch something. And so she did, and in true Amanda fashion, she didn't just take it lightly. She jumped in both feet and really got activated in the pro-life movement. And she called me up and she said, "Christina, you're a woman, you're an OB-GYN, you're a Christian, and you say that you're pro-life, but I don't think that you're doing enough, and I think you need to be doing more."
Wow.
Yeah. That's exactly what I said. And of course I was like, "What do you mean? I've always been pro-life, I'm taking care of women in their pregnancies." And she said, "No, I really, really think that as an OB-GYN, you could have a really unique voice in this issue. And it's a really important issue." And it's a long story then how my path changed, but short answer is that I got exposed to solid pro-life apologetics, Scott Klusendorf, Life Training Institute, and heard the pro-life case laid out in a way that I'd never heard before, argued with logic and reason and science and philosophy. And it really was life-changing for me. And it made me realize that this is the greatest injustice of our time. And that maybe she was right, as an OB-GYN, maybe I really could have a voice in this. And I didn't know what that was going to look like. I came home from Kenya and was like, okay, I'm here. I'll do whatever. I don't really know what that's going to be. But in the course of all of that, I got introduced to AAPLOG. And my predecessor in this role at AAPLOG, Dr. Donna Harrison, who is a giant in pro-life medicine. She has been a stalwart, especially on the issue of the abortion pill, mifepristone. She has been sounding the truth about mifepristone since before it was approved in 2000. So I had the immense privilege and honor of meeting her and joining the AAPLOG board. And honestly, I still sometimes don't know how I ended up becoming CEO. I think, honestly, a lot of it was I was passionate and I was willing to serve and willing to do whatever was asked of me. And so, when you have those two things combined, you don't know what's going to happen, but the Lord can certainly do amazing things. And and have been privileged to serve as CEO at AAPLOG since March of 2023. So it's been a little bit of a wild ride, but totally worth it. So.
Yeah, well, sometimes when you get assigned roles or hired into roles, sometimes maybe it's not you pulling the short straw, it's pulling long straw or whatever it might be. And I've been on several boards now, and sometimes it's like the last person to say no is the person who gets volunteered.
Well, I served as our board chair at AAPLOG for 6 years. It was supposed to be I think a 3-year stint. It turned into a 6-year stint, and that's how I ended up as board chair. Was I was the only one who was like maybe willing to do it, So. But I think it's just, we've got an amazing board, an amazing support system, and really and truly, what an amazing organization to be able to lead. I think AAPLOG's existence is crucial now more than ever before, especially in this post-Dobbs world that we're living in. So
again, we're talking with Dr. Christina Francis of AAPLOG, the CEO. We've been seeing a lot in the news about some potential court cases and other things that have been happening. Can you talk a little bit about those?
Sure. Well, there's lots going on, and sometimes it's hard for even me to keep track of the cases that we're involved in, but there's many other ones out there too. I think, some of the big ones that are happening right now, in fact, just recently, I believe Texas and Florida signed on as co-plaintiffs to the state's case against the FDA over the deregulation of the abortion pill mifepristone, which is very exciting that more states are joining in on that. AAPLOG was one of the plaintiffs in the original case that was brought against the FDA. People might know that as Alliance for Hippocratic Medicine v. FDA. That unfortunately the Supreme Court decided that we as physicians didn't have standing to bring that case, but all of the lower courts actually sided with us on the merits, and now the states have taken up that case. And so we have actually very high hopes that if the FDA does not, before this case is litigated, decide to reverse course and reinstate those essential safeguards around mifepristone, that the states will be successful in, at the very least, getting that done, if not getting the drug pulled off the market because of how dangerous it is. So I think that's an important case to keep an eye on. Just as a very quick overview, if people are listening and they're not aware of what I'm talking about, mifepristone, the abortion drug, was approved in 2000 by the FDA under a rapid approval process, which typically is reserved for drugs that are treating life-threatening diseases. And so in order to do that, they had to classify pregnancy as a life-threatening disease, which in and of itself is ridiculous. But they put it in place. They recognized that this drug was a very high-risk drug with significant complications associated with it. And so to minimize that, they put in place some essential safeguards limiting how far in pregnancy it could be used, saying women had to have an in-person visit before and after taking the drugs. All complications had to be reported to the FDA and a few other things. In short, since 2016, those safeguards have been systematically eroded to the point where now these drugs can be dispensed online with no meaningful screening whatsoever. For women, no follow-up. Women are being abandoned to their local emergency rooms when they do experience complications. Of course, many people might be aware of the report that came out recently from two different organizations, Ethics and Public Policy Center and an organization called FFROA, that looked at insurance claims data. So it looked at data from the real-world use of this drug and showed that the severe complication rate was close to 11% of women who take this drug versus what's on the FDA label, which is that is less than 0.5%. So about 22 times more than what's on the FDA label right now. So this is a significant issue for those of us who see patients in the emergency room. We are seeing regular complications of this. And the other sort of impact of that this is having is, states like mine, Indiana, have passed strong pro-life laws to protect preborn children in this state, to protect women from the harms of abortion. And yet, honestly, as long as this drug is available online, it doesn't matter what laws states pass, because we're seeing patients in Indiana all the time with complications of this drug, women who are getting the drug online and then are suffering complications. So this is, I think, the most important court case for people to be watching right now, because it has such a huge impact. And it's something that people on both sides of the abortion issue should be in agreement about, that this is a dangerous drug. Women are being lied to. They're being told that it's safer than Tylenol. That is not true. They're at risk for hemorrhage, sepsis, the need for emergency surgery. And women sometimes in very rural areas are taking this drug, and then they have no one to go to for follow-up except for an emergency room.
Yeah, well, we've heard a lot. There are several different referendums, including the state of Missouri, where I live, around the country, and the kind of the advertising and the messaging to the general public was that women are dying in parking lots. They're bleeding out. They're being pushed away from emergency rooms and told, no, you can just go home and bleed out and just good luck because of these so-called pro-life laws on the books. And I haven't talked to one physician that says that that's true. And what you're telling me is exactly the opposite, that, abortion in all 9 months of pregnancy with pills being shipped through the mail are not the case. So tell me about, why would they be making up these stories? And is there any truth to that?
Well, so there's no truth to the lie that pro-life laws prevent doctors like me from intervening when a woman is either in an emergency situation immediately, or if we foresee that an emergency situation is coming. We don't have to wait for her to get sick, to be bleeding out before we can intervene to save her life. There's not a single state law in this country that prevents us from intervening, even if the baby is still alive. There's certainly no law that prevents us from treating miscarriage. In fact, the laws specifically say that they don't apply in the case of miscarriage or ectopic pregnancy. And in fact, my hospital system in Indiana, when our state law went into effect, which prevents all abortions other than we do have exceptions for rape or incest or fetal anomaly, unfortunately, as well as life of the mother, of course. So otherwise, all abortions are illegal in the state of Indiana other than in those situations. And the guidance that my hospital system, which is a large hospital system in northern Indiana, this is exactly what they said. Nothing changes about how we take care of patients. It's exactly the same as what we were doing before the law went into effect. And we are not allowing women to die. We weren't allowing women to die in the parking lots. I'll tell you what is leading to women hemorrhaging out in parking lots or remote from a hospital are these abortion drugs. And we're seeing that time and time again. And so this information is extremely important for the general public to be aware of, because these lies from the abortion industry are being told to make people fearful in states like Missouri, in other states, to vote for radical pro-abortion amendments that allow then for abortion with no restrictions, simply because they're afraid that women won't be able to get the health care that they need. Because the abortion industry understands that their actual position, which is unrestricted abortion for any reason through all 9 months of pregnancy, that's not popular with the general American public. But if you make people fearful that their wife, their daughter, their sister is not going to be able to receive emergency care when she needs it, then they're going to vote for something that they wouldn't otherwise vote for. So it's very important that we understand that allowing radical abortion through all 9 months of pregnancy or at any point in pregnancy is not necessary for women to receive the health care that they need. And it's not the abortion providers that are providing good health care. It's those of us who are life-affirming physicians that are providing the health care that they need.
And we hear a lot from women in our pregnancy center, but also from a lot of physicians, that they're being told that if they go to the emergency room, they are being told to lie about their abortion. Does that complicate things in the emergency room?
It does, actually. And women should be reassured that there is not a single state in the country that prosecutes women either. So if she is living in a pro-life state, but she got these pills online and she took them to induce an abortion, she's not at risk of being prosecuted. So she shouldn't lie out of fear that she might be prosecuted. But also she shouldn't lie because when doctors like me are coming into a situation in the emergency room and we haven't been taking care of that woman previously, it actually hinders our ability to take good care of her when we don't have the full story, when we don't know what's going on with her. And we know that there's a particular kind of infection, a particular kind of sepsis that is very dangerous, has a very high mortality rate, meaning it kills many of the women that it impacts, that we only see after women have taken mifepristone for an abortion. We don't see it after they've had a natural miscarriage in the first trimester. And it has very sort of non-specific symptoms. And so the only way for a doctor to be suspecting that is if they know that she took mifepristone. If not, then she may not get the immediate treatment that she needs, and she'll be at higher risk of dying from that complication. So it's very important that women give doctors all of the information that they need so that we can provide good care to her, not because we're looking to report her to the police or anything like that, but it's because we want to give her the excellent care that she needs and deserves.
Again, we're talking with Dr. Christina Francis with AAPLOG. We got time for one more question, which is what advice would you give people who are listening today, whether they're thinking about getting into the medical field or not, or just getting involved with the pro-life movement generally?
Absolutely. Well, my first piece of advice would be to do something. Everybody can do something in this movement, and we need every single person. So maybe if you are new to the pro-life movement, do what I said my friend was challenged to do. Take the next 40 days and read or watch something about abortion to educate yourself on the gravity of this issue, the prevalence of this issue, and the need to intervene. If you are in medicine, I would encourage you to join AAPLOG so that we can give you all of the evidence that you need, so that as you're defending your pro-life position, you can defend it with medical evidence, which I think is such a strong defense, and you can provide good care to your patients. For those out there who are considering going to medical school or going into OB-GYN, but you're afraid to because you're pro-life, there is so much pressure applied right now to students and residents. We want you to know that you are not alone. It is very possible to be a pro-life OB-GYN. And in fact, that's what women want. We get people coming to our website, to our physician directory all the time to try and find a pro-life physician in their area. So it is absolutely possible to be pro-life and be an OB-GYN. Know that you're not alone. We are here for you. And I think the final thing that I would say is, based off of my own experience, make yourself available and be willing to help serve wherever it is that you are in this moment. If you do that, you really can make an impact that is probably well beyond anything you ever imagined.
Well, thank you, Dr. Francis. Appreciate you being on the program. And, thank you to all of our listeners for being with us here at Living Pro-Life.
Thank you for having me.